First of all, I would like to take the lead for the first few seconds. Ladies and gentlemen, dear professors and panelists and colleagues, it is a great honor for me tonight to introduce all the panelists tonight, but I will leave them to our moderators, Dr. Rabab Safwat, an anesthesiologist from originally from Alexandria, but she's working now in London, and another moderator, which is great honor to have her tonight for the first time, Dr. Sanam Mishrova. She's working in Qatar Hamad Medical Corporation as Associate Consultant of Anesthesiology. It is a great honor to have both of them on board tonight to be moderator for this session. And all yours, Dr. Rabab and Dr. Sanam. Thank you.
بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين. Dear panelists and attendees, welcome to the Mega Online Anesthesiology course on its 8th session in 2021. Tonight is really exceptional, and that's because we've got the experts on board. They will share their knowledge and experience in the fields of intensive care medicine, anesthesia, and pain. But before we start, I would like to thank Professor Saad Mahdi and his team for the outstanding effort behind this distinguished course. And it's always an honor for me to join the team. Tonight, on the speaker side, our eminent guests, Professor Samir Al-Ansari, Dr. Mohamed Wahba, and Professor Maged Al-Ansari. On the moderator side, myself, Rabab Ibrahim, and my dear colleague, Dr. Sanam Mishrova, Associate Consultant Anesthesiologist, Hamad Medical Corporate Qatar. Onwards to our next star tonight, Dr. Mohamed Wahba. Dr. Wahba is a consultant anesthetist in Madinat Zaid Hospital, Al Dhafra, Abu Dhabi. He's got long-standing experience in anesthesia. He got his PhD anesthesia from Berkley University USA. He's board certified in anesthesia from the Arab Board in Syria, diploma of anesthesia from the Royal College of Anaesthetists, UK, ACLS instructor till present from the for the American Heart Association, multiple publications and teaching contributions. I think it's loads to say, but I'll leave the floor to him now. Tonight he will be presenting about obesity, which is a very important topic. Actually, it's a challenge to all the anesthetists. So, Professor Mohamed, the floor is yours.
Bismillah wa salatu wassalamu ala Rasulillah. Thank you very much for the great introduction. I'm going to talk about obesity in anesthesia. And I believe it is the material for a lot of questions and discussions, and it will show how talented the anesthetist in dealing with such a case. I'm going to change your mind about obesity to tell you that obesity is the good sign of health. You will agree with me if it was not associated with any disease. So let us start. I have nothing to disclose. Any material, it was my thorough investigation through the nets. Any medication is mentioned here, or any instrumentation I'm going to discuss is merely for the academic help to my colleagues. First of all, I will going to tell you my road mapping for my presentation. I have few objects. First, I will talk about the definition of the obesity. Then I will talk about the metabolic syndrome, airway in an obese patient, pharmacology of medication for all the obese patients for anesthesia. And the main subject is, can an obese patient be an outpatient to do procedure and go home on the same day? And guidelines. And then we'll discuss few points regarding the expected problem and the anesthetic management of these cases. So let us start with obesity. what is the definition of obesity? Any abnormal or excessive fat accumulated that present a risk for health is called obesity. Based on the height and weight, if we took the weight and divided by the height square meter, we'll get what is called the BMI. BMI is the body mass index. The FDA identified the obesity based on the body mass index. If the body mass index is 18 to 24.9 is normal. If above 25 to 29.9, it is overweight. If it is more than 30, it's called obese. And if it is more than 40, it's called super morbid obese patients. Good. I don't need to remember this. You only have a scale. You have your body weight on the right axis, and you have the height on the left axis. And you can, by identifying your body weight and the height, where are you in the land of health as a point on that scale? Are you obese, overweight, healthy individual, or underweight, or super morbid obese? As I said, obesity as such is a sign of healthy person, because any disease usually causes reduce the body weight. Whenever you see someone on the street and he is pale, earthy looking, you will tell him, what is wrong with you? But you will never see an obese patient and will tell him, oh, you are sick, never. Anyway, unless the obese patient has got some comorbidity like hypertension or increase the serum triglycerides or high density lipoprotein or associated with impaired fasting glucose, is a diseased obese patient. Why I'm telling you this? Because the obese patient with hypertension and diabetes, according to the British Journal of Anesthesia, published in year 2015, said that unfortunately the obese with hypertension and diabetes has higher fold of developing cardiac adverse effect, ischemic heart disease, arrhythmias, and hypertension. 2 to 3-fold increase in the pulmonary events like pneumonia, severe chest infection, and so on. 7-fold increase in acute kidney injury. 2-fold increase in the transient ischemic attack and the stroke. For that reason, we have to treat any associated disease with obesity to avoid any one of these fold increase in the complication. As I said, obesity as such is the healthy sign. Some super obese are metabolically healthy. This was the strong statement came from the British Journal of Anesthesia in year 2016 to tell that weight loss is induced by illness. So obese people are metabolically healthy. We will take the waist circumference as a better reflection of obesity and the metabolic health. Big statement from the British Journal of Anesthesia, year 2016. But for us as an anesthesiologist, we have to put few consideration for us. As an obese patient, I am an anesthesiologist, I have to take care of 4 things: airway, chest, cardiovascular, and liver. Remember this because it is very important for those patients. You have to thoroughly dig into those systems to avoid any complication. Airway always, whenever we talk about obese patients, we have a high risk of difficult intubation. As I said, weight alone is not a predictor of difficult intubation, but sometimes if we take an obstructive sleep apnea as such, that will tell us that the airway could be compromised. What is obstructive sleep apnea? Obstructive sleep apnea is the muscle support the soft tissue of the throat, like the tongue and the soft palate. When they relax, the airway get narrow or closed. So you have to be cautious to avoid relaxing those group of muscles to avoid any complication during your anesthesia, either induction or at the time of extubation. So they take the large neck circumference as a reference for this type of airway. If it is more than 42 centimeters, so you should expect to have an airway difficulty at induction. Also, as an anesthesiologist, you do what is called the Mallampati grading. Mallampati grading, we'll discuss this later on in a few minutes. But those patients are Mallampati grading 3 and 4. Now, to predict the difficult airway, what you have to do? You have to do mobility of the neck to see if the patient can do that. And also we have a very interesting, simple way of testing the airway. It's called the external dimension, 3-3-2 rules. Everyone knows it. Ask the patient to open his mouth widely. If you are admitting the 3 fingers, index, middle, and ring finger, that is okay. And you can test the distance from the tip of the chin to the hyoid bone. If it allows the 3 fingers, you are safe. And the 2 fingers from the floor of the jaw to the thyroid cartilage, it is okay that the patient will not, or you predict that there will be no difficulty in the airway. Unfortunately, the Royal College of Anesthetists and the Difficult Airway Society in year 2011, they did a task force for the complication of the airway management, and they said that major complication of the airway in UK were the failure to document the airway examination in an obese patient. Doctor saw the patients, identify the patient is difficult airway while he doing his recording for the pre-operative anesthesia evaluation. He forget to write that the patient is having expected difficult intubation. Another anesthetist come next day to put him to sleep, and he did not see any documentation, and he ended up with difficulty in the intubation. So to predict the difficult intubation, we usually do the test I mentioned, but you have to document. And there are some obvious marks like protruded incisors and the oral dimension. I have to mention here the Mallampati grading. Mallampati grading of those patients, when they open the mouth, what you can see. If you see the tongue only, he is class 4. Tongue and the base of your uvula, 3. Tongue, uvula, fully, it is grade 2. Tongue, uvula, and the soft palate, this is grade 1. So usually those patients are between 3 and 4. Okay, now moving from the airway into the respiratory reserves. The respiratory reserve of those patients is very critical because as the body mass required, the cardiac output increased. But unfortunately, the functional residual capacity of those patients is reduced in the obese patients. Not only the functional residual capacity, it is also the expiratory reserve volume. This is how the buffer happens between the heart rate and the respiration. Heart rate is 60 beats per minute. Respiration is 12 breaths per minute. Between these 3 heartbeats, how can we aerate the blood through the functional residual capacity? Those patients has a smaller functional residual capacity, expiratory reserve volume is less, and the closing volume of those patients is high. So no reserve. That's why they are very prone to develop hypoxia with minimal, as soon as they put to sleep, they have hypoxic event. That's why cases like this, as we're going to mention later on, they need to be kept on oxygen for a longer time. to avoid or to give a safe conduct against those periods of hypoxia. Also, whenever we put the patient to sleep, because of the huge neck, huge mouth, and the anesthesiologist will not be able with one hand to put a good seal for the nose and mouth, they have to use two hands to seal this. Unfortunately, with the positive pressure ventilation, while bagging the patient at induction, some of the air goes into the esophagus. The air goes into the esophagus will be moved close to the pleural pressure in the lung, moving it from the negative to a positive pressure that will allow the basal lung alveoli to be atelectatic, more helping in the hypoxic pattern. So how to solve this problem? One, avoid keeping the patient in a supine position ever before you put induction to the patient to sleep. Always give him pillows, linens, whatever, to allow the sternum to be at the level of the jaw by raising the head by 25 to 30 degrees head up tilt, or try to give oxygen as long as you can through the nasal cannula, 5 to 15 liters per minute, or also giving him CPAP or PEEP before you put him to sleep. This will keep the atelectatic alveoli at the basal part of the lung open. This will give you more room against hypoxia. Nowadays, we have a new device called the ramp. This ramp is operated by the pedal or operated by the joystick that will allow you to have a better position of viewing the vocal cords at the time of induction of anesthesia, adjusted as much as you feel comfortable to see the ideal view for intubation, providing that the sternum is at a lower jaw level. Now, we solved out the problem of the lung reserve and the airway. How can we induce that patient? As I said, obese patients have a high incidence of aspiration. So what can we do? Prolonged airway manipulation and the difficult minute ventilation. These are the two tasks the anesthetist face. I don't want to have too many time manipulating the airway, quick, rapid intubation, and also avoid the risk of the aspiration. What shall I do? Shall I lose short-acting muscle relaxant like succinylcholine, or I will use non-depolarizing muscle relaxant? If I am in front of you guys, I will ask you who will raise his hand to say, I am with succinylcholine, safe, conduct, quick. I can guarantee that I will intubate within 60 seconds. Some other people, they will tell you, no. We are dealing with those patients and we know all the side effects and the complication of succinylcholine, like post-operative myalgia, severe muscle pain, arrhythmia because of the potassium release, and also that muscle fasciculation will drain the oxygen into the muscle, so the patient will not have enough reserve to withstand. So I will go with the long-acting muscle relaxant. What type of long-acting muscle relaxant can achieve this good 60-second intubation process? Who will tell me? Rocuronium, exactly. Rocuronium with a dose of 1.2 milligram per kilogram, not 0.8 as a standard, you can achieve intubation with 60 seconds. Good muscle relaxation, but it depends on you as a doctor. If you failed to intubate with the long-acting muscle relaxant, what will you do? The answer is laryngeal mask. Laryngeal mask is considered as the safe tool to save yourself, save the patient, provide oxygenation till you fix your problem by putting a laryngeal mask. Then think, what can I do? Shall I reposition the head? Shall I use CMAC again? Shall I use the glidoscope? Shall I use McCoy blade laryngoscope or fiber optic, or wake up the patient? and get more experienced doctor to help me. So laryngeal mask is very safe tool. It is one of the tools required for the failed intubation problem. Okay, now the life is not ended at the intubation, guys, because the extubation is another nightmare. In year 2009, the Anesthesia Management of Difficult Airway publication came to tell that 37% of the brain damage related to the induction, and on top of that, 67% of the brain damage occur at extubation for the obese patient. Why? Because you failed to extubate him the proper way. You failed to reverse the muscle relaxant of this patient. You failed to notice that this patient is obstructive sleep apnea, and he ended up by closing his airway, and you failed to re-intubate him again. So extubation is very important. It is a nightmare for the anesthesiologist in the supermorbid obese patient. So you have to check that full reversal of muscle relaxant given, and use the multimodal opioid sparing analgesics, and the screening those patients for obstructive sleep apnea, as I mentioned earlier. Pharmacology of medication is very important to understand how is the metabolisms, how is the absorption and the excretion of each drugs, and also what is the mechanisms of the drugs for us. Knowing that we have patient full of fat, adipose tissue mass is high, we have a patient with high cardiac output, we have a patient with a plasma binding to the drugs is very compromised. All these are high up for the obese patient. So I have to think thoroughly about my muscle relaxant, about my hypnotic medications, about my opioids medications for those patients. If we remember from the old days about the volume of distribution, we would remember that the volume of distribution depends on three phases: intravascular compartment, extracellular compartment, and the total body water. In the plasma compartment, depend on the plasma protein. So if the patient has got high plasma protein binding, you lost half of the medication. For the extracellular muscle relaxant, work on this. If the medication is non-ionized, it is a diffusible. If it is ionized, it is non-diffusible. So it is lost. Also, because of the total body water or the intracellular compartment, the hypnotic medication like propofol work here very nicely. So you have to remember the lipid solubility, protein binding, and the degree of ionization of this medication to deal with medication you are going to use and complete your task by conducting a safe anesthesia to that patient. As I mentioned, liver is very important for the metabolism. You have to check for the albumin, globulin, fibrinogen, alkaline phosphatase, bilirubin, and the PT prothrombin, SGOT and SGIPT enzymes. The metabolism in the liver depend on two phases, either oxidative reduction or conjugation with glucuronic acids or sulfuric acid. So be aware about the metabolism of acetaminophen and paracetamol for those patients. Apart from all this, imagine the FDA kept us silent. They never mentioned anything regarding the obese patient to adjust the dose. Surprisingly, never conduct any study for the obese patient to tell you that you have to reduce the dose, or you have to increase the dose, or you have to keep the dose as it is. Very surprising? Yes, very surprising. Anyway, they only mentioned that the total body weight and the ideal body weight, it is the height minus the height minus 100 for the male, height minus 105 for the female, and the lean body weight, which is the body weight minus the fat, and the BMI or the body mass index. Then they tell us that the optimal intubating condition for the succinyl choline depend on the total body weight. fat, muscles, bone, everything. And for the recommendation for the non-depolarizer is to remember that the ideal body weight should be taken in consideration, and for the propofol, the lean body weight, because it goes straight away to the brain. My question is, obese patient, after all this, can be an outpatient? The answer is yes. How can we do that? If we select the patient properly, if we select the comorbidity properly, we can achieve this. BMI less than 60, no obstructive sleep apnea, not associated with cardiac disease or minimal control, poor control of diabetes, never use it, oral hypoglycemic, no insulin, and he should not be leaving more than 1 hour from the hospital, and the surgeon definitely will not anticipate to take more than 2 hours for the procedure. Those are the criteria taken to allow those patients to be short stay and day case surgery maneuver. What type of operation can be done for them? Liposuction, abdominoplasty, blepharoplasty, and reduction mammoplasty, sleeve gastrectomy. I did 100 cases, by the way, with one of the eminent surgeons in Abu Dhabi. Sleeve gastrectomy going on the same day home? Yes. And upper GI endoscopy for the balloon insertion. This is bread and butter. We do it every day, by the way. Morbid obese going to have a balloon insertion and go home at the same day. These are the patient with fulfill the requirement to be a short stay cases, take a cannula in their hand, lock it, go home on the same day. But sometimes the patient need to be admitted if they have one of these, either pain, nausea, somnolence, discomfort from the upper GI after the balloon insertion. Sometimes they be staying in 1 day in the hospital. Aggressive selection of the patient for this procedure is very important. Aggressive use of antiemetic, aggressive use of the multimodal analgesia, opioid sparing is very important. Guidelines. Do we have a guidelines? Unfortunately, we don't have till year 2013. While when the American Society of Anesthesiologists did the task force in year 2013, after 23 studies for the ambulatory surgery, they came out with this conclusion: BMI less than 40 with controlled comorbidity, or BMI 40 to 50 case by case selection on a team called the board for a case. They select what is the ideal procedure could be done for those patients if they are proceeding. Now, as an anesthesiologist, to end my presentation, what is the expected problem? Reduce the functional residual capacity, vital capacity, and compliance. Closing volume is above the functional residual capacity, that means hypoxia. Airway difficulty, if you select the patient properly, you will have no problem. Predominant diaphragmatic respiration, avoid the hypoxia while intubating the patient, and give oxygen, put him in a 45 degrees, 30 to 45 degrees head up tilt, and select the proper way of intubating the patient. Difficult in non-invasive monitoring. If you remember, this patient, see the blood pressure cuff is on the forearm. How can you get a good blood pressure reading with a cuff like that? Because there is no suitable blood pressure cuff for him. Gastric stasis and esophageal reflux. Difficulty in venous access. I had a patient, believe it or not, I failed to get an IV, super morbid obese, going for tonsils and adenoid, and I have to put a central line for her after the approval agreement for the family. She was 14 years old, and I failed to get an IV with everything, the illuminating lights, attempting proper cannulas, and I failed till I put a central line, internal jugular vein under ultrasound guided devices to achieve venous access. Problem with regional blocks. Some people will say, oh, no. This is very good for the regional blocks. Dr. Magd Al-Ansari will say, yeah, Wahba, عيب عليك. It's not, you should give regional blocks. I agree. If it is supraclavicular block, internal axillary block or so, but for a spinal, be aware that these patients are predominantly diaphragmatic respiration. So you will achieve one thing and you will lose another by inadequate spontaneous breathing. If you paralyze those muscles on those patients when they are lying supine, you will lose them completely. if the block is high up. And it is technically difficult, but if you can use an ultrasound with a longer needle, you can achieve a better view. It is up to you as an anesthesiologist to decide. Problem, positioning, and mobilizations, check the table if it is suitable to accommodate 250 kilos or not. And the prolonged surgery, if it is more than 2 hours, no, this is not a candidate for short stay procedure. Now, finally, those usually patients associated with frequently with diabetes, hypertension, and a metabolic syndrome. What shall I do at the end of the day for this? I have to assess the cardiovascular, airway, respiration, and the liver. And you know the investigation required for those cases. Pre-medication, thank you very much. Avoid giving any opioids. Only use antiemetics, cimetidine, ranitidine, metoclopramides. Monitoring as much as you can. Use the proper monitoring. If you fail to have the proper monitor of the blood pressure, you can put an arterial line for those patients. Urinary catheter, end-tidal carbon dioxide is very important. Induction, pre-oxygenate nicely for good 3 minutes. Using the PEEP CPAP maneuver, 30 degrees head up tilt, and high nasal cannula oxygenation 5 to 15 liters to avoid this hypoxic pattern. Maintenance, try to use all the drugs which will not be metabolized through the fat and will cause redistribution again. Regional anesthesia, as I told you, it's technically difficult, but it is up to you to decide. If it is limb, like axillary, supraclavicular, or femoral sciatic, it's okay, but be aware about the spinal and paralysis of the diaphragmatic. They are diaphragmatic predominant respiration. Recovery is very important because you need to extubate in a 45 degrees head up tilt, nurse it 45 degrees head up tilt, good analgesia with epidural or PCA or PCEA, because the patient should share with you on his pain treatment. Early ambulation, of course, and physiotherapy. Post-operative is very important for early mobilization, and came to the last slide, which is my conclusion. Only the long-term effective treatment for the BMI more than 40 or 35 with comorbidity. As we are talking to the COVID-19 now, Dr. Maged Al-Ansari, Dr. Samir Al-Ansari, both of them are going to squeeze me for the COVID-19. I have to tell that if you are seeing your patient in the pre-anesthesia clinic and you're afraid to let the patient expose his face mask for the infection or something, because we usually see the patient and send them to the COVID clinic to get the swab to check that they are negative. What you do, ask the patient to go home, take the mask out and take a selfie for himself and lateral view, face view, and send it to you on the WhatsApp. Approaching the patients, as I said, one risk factor, do ECG plus the routine, and 2 or more factors, do further testing like lung function test or liver function test for those patients. With this slide, I came to the end of my presentation, and thank you very much for giving me this opportunity to discuss the term of obesity and anesthesia. Thank you very much.
Thank you very much, Dr. Wahba. Let's get started with questions now. So Dr. Mohamed Sulaiman is asking, can you please highlight the preferred mode of ventilation and oxygenation during anesthesia induction in obese patients?
Well, those patients, because they are obese, they are dependent on the ventilator for sometimes. So we always recommend to use a pressure cycle ventilator with the muscle relaxation, because that will give you a better oxygenation and open the atelectatic alveoli. As I said, we sometimes use PEEP for those type of ventilation till they finish the procedure, and then we wake them up. Sometimes it is not advisable to extubate the patient immediately, because as I said, obstructive sleep apnea or oxygenation is not optimal. So we send them to the ICU, depend on the procedure done for him, and then slowly extubated on the proper way.
Thank you very much. And we have a comment from Dr. Yasser. He's saying, despite obesity is associated with many medical problems and is a risk factor for cardiovascular diseases, we have obesity paradox. In 2020, many articles were published about the protective effect of high BMI in acute medical conditions, as well as less complications during the postoperative period. What is your comment?
Thank you, Dr. Yasser Zaghloul, for this nice, beautiful comment. As I said earlier, we are coming to change the idea of telling that the obese are sick. The obese are healthy people, but with some modification. So don't get afraid or worried about putting a patient to sleep for a procedure X or Y. But you have to tackle those problems thoroughly: the airway, the lung, and the liver metabolisms, and finally the cardiovascular system for any comorbidities. Managing all these together make the impossible possible, or even making the possible easy to handle those type of patients, and safe conduct of anesthesia ending up with a beautiful outcome.
Thank you. And we have another question from Dr. Mohamed Suleiman. He's asking, ultrasound-guided venous cannulation helps in obese patients. However, it needs special long cannula because the big layer of subcutaneous fat. Do we have such cannulas?
Yes, we have such a cannulas, but it's mainly an ICU called the pig cannula, pig tube. This is like cephalic catheterizations going through the antecubital vein, and goes through the cephalic vein up to the chest, like what's it called, the superior vena cava, but used for a long-term type of IV medication like TPN and these sort of medications in the future. But we don't use them for the day case procedure. My aim today is to tell that we can do obese patient as day case surgery. As I agree that ultrasound could be used, but as I said, that the thick skin could be an obstacle for identifying the superficial veins for those patients.
Thank you very much. Dr. Mohamed Suleiman again asking, what is
لا يا Dr. Mohamed Suleiman is too much for you. Give the chance for somebody else to ask. Go ahead.
So what is your advice to these patients before deciding to proceed to bariatric surgery?
Before?
What is your advice to obese patients before deciding to proceed to bariatric surgery?
Okay, now I believe that the bariatric surgery now is the talk of the century. In Dubai, as I'm telling you, those cases are day case surgery procedure. They are BMI is between 40 to 50, and they are doing as routinely. I had 100 cases done last year with one of the eminent professors in bariatric surgery. So what we have to tell them that number one, pain treatment is very important for post-operative management. Sometimes they have to expect, if there is any complications or bleeding or leak or whatever, they have to be admitted in ICU for observation, and they have to change their feeding habit from now on. After gastric sleeve or bypass surgery, they have to change completely their lifestyle. This will improve their ability to lose weight nicely. At the same time, they will maintain their physical exercise to allow the reduction of that redundant skin. So they have to do effort. It's not only I'm going for surgery to lose weight and then I live my sedentary life again, eating junk food again. No, they have to change their life habit completely for that.
Thank you very much. Now we have another question from Dr. Isawi. Why spinal anesthesia is contraindicated in obese with diaphragmatic breathing while diaphragm is supplied by phrenic, which is C4, 5, and C3?
Very good questions, but he did not realize that I am not saying it is a contraindication, but you have to be cautious. You have to caution with the spread of your local anesthetics after spinal and let the patient lie supine. Diaphragm is supplied by the C4, 5, and 6 cervical up there, but you remember that also the intercostal share with the muscles of respiration. So if you are good enough not to allowing that spinal anesthesia to spread up to allow the weakness of the intercostal muscles, you are predominantly on a diaphragmatic respiration. Any patient lying in a supine position, normal, not an obese, he will lose 30% of his vital capacity while he lying supine under this paralysis of the abdominal muscles. Imagine this obese patient with predominantly diaphragmatic respiration. You are talking about 40% of the vital capacity is lost. So you have to be cautious. If you are planning to do spinal anesthesia, you have to do saddle block. You have to, for inguinal hernia, do not allow the spread of the block above the T10.
Thank you very much. And we have a last question. Interscalene and supraclavicular blocks can also paralyze the diaphragm. Do you think it should be not used?
No, it should not. It should not cause this. We are talking about an ultrasound guided device which will identify where is the bundle, the trunks, the division, the cords of the brachial plexus. Where is the diaphragm here? Where is the recurrent laryngeal nerve for those nerves? It's quite far. It's not quite far, but actually you can, with the ultrasound devices, navigate through the dangerous structures and identify your plexuses which will need a block. I'm not going to tell you that interscalene as such is a problem, because the interscalene will go up a little bit very close to the roots of the brachial plexus, but the supraclavicular block will not cause any diaphragmatic paralysis for the block.
Thank you very much. And I have a few questions from Facebook. Dr. Ayman is asking, what about inhalational AL induction and sevoflurane?
Yes, inhalation is very important. And as I said, in the inhalation, we have to look for the medication which will not co-metabolize inside the body, or at least like 0.002%, like desflurane or isoflurane, 0.2% is metabolized only in the body, and the rest goes with exhalation. This is very important not to allow any residual, because the fat will retain some of these inhalational anesthetics that will cause the recirculation again and again and again, and the patient will not recover smoothly from the anesthesia. Do as much as we can by using the medications for the inhalational anesthetics, which will less metabolize and stay in the inhalation for quick exhalation rather than to be metabolized in the body.
Thank you very much. So